Thank you so much, Jeff, for that introduction. Hi, everyone. Good afternoon. I know it's been a very, very long day, so we're all going to try and keep it really, really brief. And we really appreciate that you're all here to listen to us talk about this really critical issue, which, as Michaela said, is an emerging agenda for a lot of us here at the conference. I'm going to be presenting on a research, an initiative actually, that is being led by the HIV Young Leaders Fund in partnership with our colleagues at the Interagency Task Team for Young-Affected Populations in Asia Pacific, including UNESCO, UNICEF, UNAIDS, UNFPA, Save the Children, and Youth Lead. One second, let me just figure out how this works. Okay. So adolescents under the age of 18 are engaging in selling sex. And this is not something new. It's new in the sense that we don't have a lot of evidence around it. There's little age disaggregated data that's available to us. And from what's available, you can already see that this is actually a reality across the region in almost all of the countries that were part of our research. In Nepal, you can see between 16 to 33% of females in the sex industry started below the age of 18. The median age that's reported among female sex workers in Maldives and Papua New Guinea was 17 to 19. In Pakistan, you can see male sex workers reported that they entered the sex trade under the age of 18, which is mean age was 16. So it's not something new, and these adolescents are operating in a variety of venues, in a variety of contexts, and part of our work was to sort of understand that better. Adolescents face increased vulnerabilities for various reasons. One of them definitely is that they're biologically more immature, so more prone to the risks of STI and HIV. Another one is that they tend to have higher number of sexual partners, particularly when they're engaging in selling sex. There's a larger demand for younger sex workers than the older ones. They have more frequent unprotected sex because the circumstances in which their sexual relations happen are much, much varied. Often with lovers or intimate partners, they are not as prone to using condoms as they might use with a client. Or if they don't identify themselves as a sex worker, their risk perception of whether they should use a condom or not also becomes varied in that context. They're far, far more hidden and underground because the activity itself is criminalized. As people under the age of 18, it's very, very difficult for them to openly engage in selling sex, even in the red light district itself, where a lot of the times sex workers over the age of 18 try to disassociate with them in the attempt to not attract police attention or law enforcement attention. So they are far more underground than your conventional sex worker population. And they have multiple overlapping risks, which may include a higher tendency to use drugs as a coping mechanism for what they're going through, what they're experiencing. So the initiative is called, oops, I have to move this also. Sorry, just kind of forgot to move the slides. The initiative is called Health Equity for All, and our aim was to better understand the experience of these adolescents in accessing healthcare services, particularly looking at HIV and SRH services, sexual and reproductive health services, and also at the same time identify what is actually working, what are the kind of strategies that are that these adolescents are developing on the ground to cope, to survive, and what are the kind of recommendations that they would want to give in actually addressing some of the barriers that they face in accessing these services. We wanted to do this through a dialogue with the adolescents themselves and with the stakeholders. So our approach was multi-pronged. We did a literature review where we looked at available studies, research across the region, found almost 100 of such studies that we reviewed to look at what are the gaps in the data, what are the gaps in our knowledge, what is the insight that's already out there. Then we did in-country focus group discussions across 7 countries. This was again to get a bit more of the grassroots perspective from the adolescents themselves and some of the stakeholders that were working with them. The country consultations were done in Bangladesh, Cambodia, India, Nepal, Vietnam, and Indonesia. And they were hosted by local organizations who had access to young people who possibly initiated into the sex trade before the age of 18. So we primarily did our focus group discussions with young people between the ages of 18 to 24, but people who had experience of working in of sex work under the age of 18. And this was obviously for a lot of law enforcement and ethical reasons, but the idea was to get experiences out from these discussions. The discussions were led by peers, and the discussions were often in the local language, so it facilitated a more honest and a more detailed response from the adolescents. We did a regional consultation in Bangkok, followed by this, which was to bring all these young people from different regions together and sort of bring together a commonality in the experience, and also look at some of the recommendations that were coming out. In the day 2 of the consultation, we invited certain stakeholders, including the UN partner agencies, to come and listen to the adolescents themselves and sort of interact with them and together look at what are the programmatic areas that they can work with each other on. So that was the work that's been done so far. And the last part is releasing a finding report, which we'll be releasing sometime next month. But I have a sneak preview here if some people would like 1 or 2 copies. So you can take that after the session. I think one of the main important discourse for this session is to look at the risk. And before we go into the risk perception, risk management aspect of it, the risk landscape itself for the adolescents is very, very complex, and it's very, it's multi-layered. So we started by looking at the risk which happens at the initiation level. So this is looking at the motivations that young people or adolescents have when they start engaging in selling sex. And it's a full range of motivations and reasons that goes from economic survival, sexual initiative, to even forced sex. So it's more of a spectrum, as you can see, on which you put a continuum of volition, which is the agency that young people have and exercise, or adolescents exercise, in choosing to engage in selling sex. And the insights that were coming from our research was that you require a different set of intervention at each stage to address some of these risks. The second layer of the risk landscape comes when they're already engaged in selling sex. And this risk landscape, this layer of risk is actually dynamic. Like Michaela also said in her presentation, the risk landscape is very dynamic. It depends on the nature of involvement of that adolescent, which includes the kind of sexual acts that are being performed. In Bangladesh, there's a study with male sex workers which identified very complex behavior patterns among adolescent male sex workers, which included transactional, non-transactional, commercial, non-commercial, penetrative, receptive, sexual behaviors, and sometimes with intimate partners who were their lovers or sweethearts, sometimes with clients. So it's not like the previous presentation pointed out, it's about risk moments and not so much, a continuous state of risk perception. And the landscape is very dynamic. The nature of involvement greatly affects what kind of risks are coming into play at what point. The location and the ways in which the adolescents and young people work also affects this risk. One example is that a study in Thailand found that younger members between 14 to 25 are have more of a tendency to freelance. So it's harder to reach them because they're such a mobile population, and they're able to their clients are not geographically confined. So this service, from a program and service point of view, it becomes difficult to manage that kind of risk, and the location effects in how they are, how different risk exposure happens in that context. The third thing that affects their risk is clients, the kind of clients that they get. Oftentimes in our study, we are finding that you have uniformed officers as clients, and that kind of adds in another layer of risk, because I can just actually share some of the study with you. In a study from Nepal, we found that the majority of clients were government officers, army, and policemen. A study in Sri Lanka found that a majority of clients were businessmen, tourists, and even soldiers who purchased sex from female adolescents under the age of 18. All of this put together, completely changes the landscape for these adolescents, and it's a continuously changing landscape. So much so that in Cambodia, one study found that changes to the working conditions and nature of selling sex for 15 to 20-year-old females have increased their access to amphetamine-type stimulants, and this brings in another layer of overlapping risks, not just of drug use, but also having led to increased number of sexual partners, having led to increased alcohol use, having led to increase of other STIs because of the multiple different types of sexual behaviors that were increased. Yeah, I was talking about the clients and how a large part of our research and study showed that a lot of the clients are often uniformed servicemen. And I think in this risk landscape, the third and additional layer comes from this intersectionality between health and law enforcement, where from our consultations and focus group discussions, this was a very strong experience that a lot of the adolescents share, that police harassment, arrest, interrogation, and targeting, particularly for transgender and male sex workers, and profiling them for sex work, was a very frequent experience that they had. And then one of the studies done by ECPAT in Hyderabad also showed that the police targeted adolescents, male engaged in sex work, and 30% of them reported police violence, including rape and sexual assault. So there are these evidence coming out, both from the research that we reviewed for the literature review and from the focus group discussions around how interactions with law enforcement and the law enforcement setup at country level often contributes to another layer of risk for the adolescents. One of the consultation participants actually gave this quote: "Police force us with three options: pay money, have unprotected sex, rape, or arrest, or physical and verbal violence and arrest, or you get arrested and you get published in the newspaper the next day." So there's a lot of difficult risks that they have to navigate through, sometimes with the very people who are charged with justice and protecting their human rights. So in this kind of a landscape, it's very difficult for these adolescents to manage the risk. They face massive barriers to health care services, which also include parental consent issues, which include discrimination from the healthcare provider themselves. And this hampers their ability to manage these multiple overlapping risks. It hampers their ability to access something as simple as condoms to protect themselves. One of the consultation participants actually reported that carrying a condom, which was given by a healthcare service provider to them, was actually going to put them more at risk for being bribed by the law enforcement, because they would be labeled as sex workers and then would be arrested. So it becomes quite much of a challenge for them. One of the very clear barriers that came out from our consultation was that adolescents don't have independent access to HIV and sexual reproductive health services in the government settings and the public healthcare settings. Parental consent is almost always required. And one of the participants from the focus group discussions shared that even if policies allow certain groups of young people, like young MSMs or young transgenders, to actually access these services, on the ground level, it doesn't happen, even though the policy says it should happen. And that's partly due to the stigma and discrimination that they face with the healthcare provider, which brings us to the next barrier, which says the services are not youth-friendly. In Bangladesh, MSM and sex work identities are not open, are not accepted. And so it's difficult to go to the healthcare provider because there's fear of stigma, there's fear of discrimination, and more importantly, there's fear of breach of confidentiality. This is really, really crucial. Confidentiality is something that, at least with the healthcare setting, is very important for adolescents who are engaging in sex work to be able to have as a guarantee if they are to go to the healthcare provider. It directly affects the quality of health care that they are getting if they can be assured that it will be a confidential service. So even though they may be motivated towards health-seeking behavior, even though they may be informed and aware, this barrier stops them from doing something which naturally should come to all of us, is take care of ourselves. So that's the next barrier is criminalization. Criminalization obstructs access to HIV and SRH services. And this is particularly so for adolescents because even, like I mentioned before, even the adult sex workers in the red light areas will not support you if you are an underage sex, if you're a young person engaged in sex work, or if you're an adolescent under 18 engaged in sex work. In countries like Myanmar and Bangladesh, the law restricts you from being open about your sexuality. This is particularly for the gay and the transgender sex workers. And if you do sex work, it makes it difficult to disclose this to service providers, especially for young people. A lot of the countries that we studied also had laws where healthcare providers had to disclose if they are providing service to people under the age of 18 who are engaged in sex work. So that creates another obligation on the service provider to not do what's more important for them, is to take care of the young person's health, but actually it prioritizes the criminal justice system over the healthcare system, which creates a big barrier for young people and adolescents to access this healthcare. The next barrier is that services are not often tailored to the needs of young people. One of the consultation participants said that sex workers, especially adolescents who engage in sex work, are functioning out of a variety of different settings, not just brothels, but they're freelancing a lot more. They use a lot more of social media sometimes. So the health messages and the kind of service provision that happens in service outreach needs to be tailored to that. The other aspect of that is they're not tailored to the issues, the specific issue of that population that's coming to them. As one of the participants said, transgender female youth who've had gender-affirming operations need specialized services, and healthcare providers still continue to service them as male sex workers and not as transgender sex workers. So this creates another barrier, and particularly so for the adolescents who are going through this developmental period where they are already in a lot of self-stigma, they are already experiencing a lot of social pressure to not be who they are, and they need that kind of affirming attitude from somebody they can trust with their health. They need that more than, say, an adult transgender person who's slightly more secure in his or her identity in that respect. And lastly, services are not safe. This was another insight that came from the consultation and the focus group discussion, that oftentimes violence is not just limited to the uniformed services. Sometimes violence and abuse is perpetrated by the healthcare providers themselves. And this is one other instance that came out, was that often NGOs that work with these adolescents force them to give blood for HIV testing in exchange for certain services like access to condoms. And there's blackmail, there's bribery involved. So it's another level of risk coming. It's another level of risk as well, and it's another barrier that comes in accessing critical health care for these adolescents. Some of the survival strategies that came up from the consultation, I think this is really important to look at, because it's inspiring to see adolescents come up with ways to beat the system, to actually make it through despite the many multiple overlapping risks that they're facing, and still go on every day managing it the best that they can. So some of them reported using paralegals from the community for legal assistance when people were arrested. One of them mentioned developing a sort of a community manual, more like a pamphlet or leaflet that was circulated among their networks saying what to do when you're arrested. One of them mentioned setting up a social media helpline where they can actually provide each other immediate assistance, and forming self-help groups, peer support groups, where they find strength in numbers in being able to help each other, not just tackle the police and the law enforcement, but also keep a track of the dangerous clients, as there's a lot of violence that happens in these settings. And as adolescents, they're not able to negotiate better or negotiate more effectively in protecting themselves from that violence, even from the clients. So that was one. A strategy that was suggested for outreach was to do outreach using non-stigmatizing names and trying not to label the groups and their behaviors, but keeping it more informal. Another strategy that they came up with was to hide condoms in tissue papers inside their socks and in empty cigarette packets so that they're not caught by the police and put into detention. So young people and adolescents are working in their own ways to come up with some of the survival strategies that can help them get through and address some of these barriers in the short term at least. But some of the broader recommendations that they came up with, and these are all recommendations that came out of the focus group discussions and the consultation that was held in Bangkok. So this is entirely what the adolescents had to say, what they needed, more than coming from anywhere else. The first recommendation, as you can see, is improving the quality and accessibility of healthcare services. And the one that they prioritized was training healthcare workers to not discriminate and to not violate the rights of adolescents who sell sex. The second one was to be able to provide multiple services in one place. So whether it is STI services, HIV test, reproductive health services, or even services like temporary housing or nutrition programs, all of that could be provided at a one single point of contact so that they don't have to go through different healthcare providers. One participant also mentioned that going to different healthcare providers sort of becomes a challenge in terms of scheduling time-wise, because you have to take appointments and there are queues. And oftentimes, if you know that a particular service provider is going to be stigmatizing, you end up going to the private clinics, and then you have to take you end up paying a lot of money to the private practitioner. So if there could be one integrated point of contact where all the services could be made accessible, that would be one of the recommendations. And then the third one for services was provide more peer and community-based healthcare services within the traditional settings and as well as outside the settings like mobile clinics and weekend hours. A lot of the participants reported timing of the service being an issue because as young sex workers and adolescents engaged in selling sex, they were often up till 4 or 5 in the morning and sleeping very much into the afternoon. But by the time they would wake up in the evening, the service provision hours would be over. So it's difficult for them to be able to access services that are not time-wise sort of put together around their needs and their schedules. They also had some recommendations around legal and policy change, the first and foremost one being removing parental consent requirements to access healthcare services. A lot of these adolescents are coming from a variety of different contexts where disclosing to their parents what they're doing is troublesome. One of the consultation participants shared that even though they were doing this to support their family, they wouldn't want to tell their family what they were doing to support them and their siblings. So it's a bit of a tricky situation where parental consent requirements actually impede access to critical services. The second recommendation was to recognize sexual orientation and gender diversity. I think it's really important that they mention this. It's not just stigma that comes from the healthcare providers, but this is important from the perspective that a lot of the consultation participants reported violence and abuse from the law enforcement happening because their states did not recognize their sexual orientation or their gender identity. So it gave the law enforcement another avenue to sort of perpetuate the abuse and the assault. So that's very important from that aspect. Sex work should be decriminalized for adolescents who sell sex. Again, this came from the fact that because it was criminalized, a lot of them could not just not access services, but face a multiple level of risks because of this. Carrying condoms should be legal and should not be cause for arrest or detention from law enforcement. This was something that came out very strongly. There needs to be communication between the health department and the law enforcement department. The health department provides the condoms outside the service center, and down the road you have law enforcement waiting to arrest you for carrying those very condoms or bribe you for that. So that there needs to be some sort of communication where the health needs are prioritized over the criminal justice system. Programs should address police violence and corruption as well as exploitation from employers and clients. Oftentimes, the consultation participants reported being blackmailed by their managers who were working with the police themselves. So there was a lot of coercion happening from that aspect. And they wanted to address it, but they wouldn't be able to go to the police to actually report it, because if they did, the police was anyways in line with the managers themselves. So if it's a difficult situation where you know that violence is happening to you, which you want to report, but there's nobody that you can report to. The last recommendation was around education and job skills. They talked about empowerment programs that could help build confidence and self-esteem. The recommendation was to tailor education program for adolescents that meets their needs, such as offering classes at different time, job skill and vocational training. And I think the most important recommendation that came out was allowing spaces for adolescents to actually talk about their experience in a safe and secure way, and also spaces where they can construct the best way for these programs and service delivery models to work for them. And this is a quote that we picked up from our literature review. It says, UNICEF's systematic review found that among HIV treatment, prevention, care, and support interventions that targeted adolescents and youth, those in which adolescents created their own system or their own structure for the intervention delivery were the ones that had the highest evidence of impact on biological and behavioral outcomes. That's pretty much it. Thank you.